Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. Our topic tonight is opioid issues for the patient and practitioner. Our speaker and my partner, Dr. Greg Caldwell. He is a national and internationally renowned speaker on the topics of OCT, ocular nutrition, wellness, and ocular disease. He is a disease consultant in Pennsylvania where he is in private practice. He is a co-owner of Optometric Education Consultants with me. He is a past trustee of the American Optometric Association. He's a fellow of the Optometric Glaucoma Society. And in 2013, Newsweek magazine named him one of the top optometrists in the nation. So with that, Greg, please take it away and deliver this very important course that a lot of people need for their licensing requirements and their education. So Greg, please take it away.
And Joe, you nailed it. That's why this course has been put together. There's a lot of states where we went through the, scope amplification back in the day. For me, the majority of them were the late '90s, early '80s. I know there were states before and much later after, but the majority of them came on, and a lot of them required this opioid course to be able to get that scope passed. But this also counts as pharma for those that are out there. So those that need the pharma credits that don't need the opioid course, we got you either way. It's COPE approved, it's CE broker approved. It will cover most states' requirements that are out there. Regarding disclosures here, I've lectured from Alcon to Lens, received an honorarium for Dompe to Envision, an advisory board. Disclosures, I've received an honorarium for those. I really don't have any financial proprietary interest in really in anything that's being talked about tonight. I will disclose that I'm a non-salaried financial affiliation with Pharmanex and Nu Skin. Not going to be discussing anything there tonight. I do sit as a chairman for Advisory Council for Diabetes and Macular Degeneration for the Healthcare Registries, which is an outcome-based registry. Here's the important bullet points right here. The content was independently prepared by me. No one's really telling me what to say. And if I mention any products tonight or any instruments, I'm not claiming any commercial bias or superiority. Joe mentioned that we are owners, each half of Optometric Education Consultants. But right up here, here's the important statement. Everything has been mitigated by the regulatory bodies. This is my practice right here. I always say science is great. We watch, we go to OGS, the Optometric Glaucoma Society meeting. They're talking about growing neurons in a petri dish and crushing them and neuroprotection and seeing what we can do to help these nerves not to die. And that's great science, but that's kind of light years away from being in our practice. So science is great, but what I try to do is be an optometric translator to try and bring it into our clinic. And that's Joe and I's goal. And every time we lecture and we participate with each other here is to just make everyone a little bit better, maybe think a little bit different when they're in clinic the next day. So that's really the goal here. Now, here's the agenda. I usually don't put that in there, but I have it in the course notes just in case you need to have this to show to your state or your state board. I've combed most of them over the years. I think the last time I did it was probably about 9 months ago, maybe 11 months ago when I was retooling this lecture, looking to see if there was anything new out there. So, they want you to discuss the opioid crisis, pain definitions, grading scales, adverse drug reactions, tolerance, true addiction, and then have some question and answer. And that's why you have the chat box there. So that's agendas. I usually don't put it in, but again, it's there in case you just need to show what was covered to your state board with this talk. So, Joe, with that being said, can you take care of the first polling question for us? With the first polling question being, I am taking this course because, and you can click all that apply. I have a DEA license. I have a DEA license and it's required. I need pharmacology credits. I am interested in the topic, or if you have something else, you'll place it in the chat box. Did we lose Joe? Maybe.
Yes, you did. Okay, they're rolling in and we're off to the races.
Okay, perfect.
I'll look at the chat box. And make sure you go to the icon that says polls to answer the poll, not in the chat box. And I think we are slowing down. So I'm going to close the poll and display it. And Greg, the majority need the pharmacology credits, followed by I'm interested in the topic. I have a DEA license that's required, and I have a DEA license. And 2 people said they'll put their comment in the chat box, and I'll go there and look. One person said all the above, and another person said favorite CE lecturers.
Ah,
So we can take that.
well, thank you. All right. So that's good to know how that, it's pharmacology, and then there's the interest in the topic. Let's jump into the lecture a little bit more, into to how we got into taking an opioid diversion. And really, the key comes down to there's an opioid diversion, but I really want to make this lecture a positive in a sense to not be afraid to use these medications. I probably prescribe an opioid, probably once a quarter, 6 to 8 times a year. And, these are great medications for pain. They work really, really well for pain. And, we shouldn't be really afraid of them because we're going to talk about acute versus chronic. And the acute really doesn't lead to the addiction. And I'm not saying anyone that takes it for 3 or 4 days can't become addicted, but the chronic patient is the one that usually becomes maybe addicted to these. Now, if you look here to the words I have underlined, this is why the National Institutes of Drug Abuse, this goes back to March 2018, that there was 115 people in the United States dying every day from overdosing on opioids, misuse of addiction to opioids. There was a serious, national crisis. Now, this isn't in 2018. This is just the statistics that kind of brought us to why we need to take these courses. Misuse, you can see underlined. Again, chronic pain. See, it's chronic pain, misuse. 8 to 12% develop an opioid disorder. 4 to 6% misuse prescription opioids, transition into maybe something heavier like heroin. 80% of the people, again, first misused a prescription opioid. Overdosed increase in overdoses. Large cities became a financial burden. So it was back in the summer of 2017 when the National Institutes of Health met with the pharmaceutical companies and started to try to work together for safe, effective, non-addictive strategies to manage, look again, chronic pain, new innovative medications, technologies to treat opioid use and disorders, improve the overdose prevention and reversal interventions to help save lives. So that's really how we ended up. Now, when we have pain, pain is a very important part of our survival. Pain is defined as a perception of a noxious or harmful stimulus. Pain can also occur in the absence of injury long after the injury has healed, right? And we've seen that maybe with post-herpetic neuralgia, that type of neuropathic pain. Pain provides humans with information about tissue damage, right? So I always use pain's not always negative. You could have a pain in your side, and that causes you to go to the doctor, and they do an X-ray or an MRI or CAT scan, and they find, oh, you got some type of maybe tumor growing beside your kidney that was pushing on your kidney, creating the pain, and they go in and take the tumor out. Maybe it's cancerous, non-cancerous, but it was something good with the pain that caused you to go to the doctor. So pain is protective in 2 ways. It removes the person from the stimulus that causes the tissue damage, and there's learning associated with it. So I always tell the story that there was we got a brand new tractor back in the day. It's probably closer to 50 years now, maybe 45 years, and I remember my dad bought it and we had it delivered, and we looked at it and we were going to cut the grass for the first time, and we were all done. That shiny muffler had turned black, and I was like, "Oh, what happened?" And my dad grabs my hand and pulls it away. He's like, "Son, that's hot." And so I'm like, "Oh, okay, thanks, Dad." And the next time I got to cut the grass, Dad wasn't there, and I'm like, "Oh, let me fill this muffler." And I burnt my finger. And here I am 45, 50 years later talking about it, to know not to touch things that, that come from combustion engines and the mufflers because they do get hot. So there's a learning associated with it. And this is, another one here. This is a patient that is, they're obviously, you can see the limbal injection. This is someone that's taking a contact lens, sleeping in it, wearing it too long, and the eye became red and painful. And that's pain is positive in this, so that the patient took the contact lens out. We all know the ones that kind of still have this and they wear it in, but yet most take it out and then they come in and get evaluated, and then we're able to treat them. So pain is positive. This person maybe was doing something abusive with the contact lenses, but yet they were, I guess, smart enough in a sense to go to the doctor and find out what was going on so they didn't have create any vision loss from it. So pain is important to our survival. Um, it's very complicated. You can remember when we were in school, we learned about all the different type of sensory modalities. The touch, the temperature, proprioception, nociception, which is the pain, the body position is the proprioception, and so the system reacts to diverse stimuli using different types of receptors, thermoreceptors and nocioreceptors, mechanico and chemo. And probably the most common or the newest that we're talking about, and when you talk about thermoreceptors, right, is the new Triptyr eye drop. So if you think about, kind of just go off onto a tangent here, our cornea, it just got cold. We had our first snow just last night. We had about 2 or 3 inches. Joe, I had to wear socks today to work. Joe always teases when it gets cold down in Sarasota that he has to wear socks. So we had some snow up here. It's a little bit cooler, and had some snow up there in Pennsylvania versus Sarasota. But
Well, Greg, I heard we just got 2 inches of packed powder in Orlando.
Perfect. The thermoreceptor that I'm referring to is with the cold weather is when patients go outside and they step outside, we have receptors on our cornea that when things change by 10 degrees, it creates watering, right? It feels that it's cooling down, and that's kind of like sweat evaporating off. Hey, they're cooling, but that eye must be cooling too. So it must be drying out. So hurry up and water. Well, those are reflex tears. Well, the other thermoreceptor, and we're talking about Triptyr, the Triptyr works on a receptor that's like a half degree to 1 to 2 degrees Fahrenheit. And when that gets stimulated, it creates the basal tear. So there we are with the receptors with Triptyr talking about the half degree Fahrenheit to the 1 to 2 degrees, that the creating basal tears, not reflex tears that you step out in the cold. So there's thermoreceptors, and we have mechanico and chemo, and that's like when you smash your finger, you have those receptors telling you what's going on. So lots of receptors, and I like this picture because when it goes to the brain and the brain tells you about pain, you can see that there's a lot dedicated to the hands, there's a lot dedicated to the face, the arms don't get much. You can see the eyes are very well represented in the brain. So that's why, as we know, the cornea is the most innervated, densely packed tissue in the body. And you can see that the brain gets a lot of, or the eyes get dedicated a lot of space in the cortex. So pain is an unpleasant sensory experience associated with actual or potential damage to the body or perception, such as damage, subjective experiences, memories of events associated with extreme pain, persistent for a long time. Mental status is known to have a powerful influence. We know about the soldier that might be in combat, has been hit with a bullet, maybe realizes it, but yet, oh, I don't feel any pain, and they're able to drag their buddies off the field, do something heroic. That once they kind of get past that part, then they realize, well, geez, there's a lot of damage here. Bone is shattered. but they were able to get over that, the mental status of that. Or we all know that these players that play with broken bones or legs, like in the Super Bowl, and then whenever they're done, they get the X-ray and find out that they played a quarter or two with a broken bone. So mental status can also be powerful over the influence of pain that's out there. Now, when it comes to pharmacology of pain management, we're gonna. I used to just talk about peripheral and central, and then I'd get all these questions about where does like proparacaine fit in. So peripheral acting agents, that's kind of the receptor to substance P. That's your ibuprofen. That's your NSAIDs, for an example. Central acting is what we're talking about here tonight. They're working on the mu, kappa, and gamma receptors. And these receptors are found all throughout the body, but in a sense, kind of blocking that signal to the brain and saying, that cortex that I showed you, there's nothing going on with that. Ignore that in a sense. But those receptors are found all throughout the body, and that's what we're going to be talking about with opioids and narcotics. So like tramadol is the one that I prescribe the most, 50 milligrams of tramadol. That's probably when I mentioned, 6 to 8 times. Maybe it's more, maybe it's close to, 12 times a year. Tramadol is great. It's a Schedule 4. We'll talk about that. And then if I get to some severe pain, then I'm, jumping over to a Vicodin, a hydrocodone type product. But we have some time tonight. We'll talk about that. But those are the ones that are central acting, and peripheral acting would be the NSAIDs and ibuprofen. So now, how do things like anesthetics and proparacaine? Well, they prevent the signal from traveling, right? So they're basically signal blocking to so like when you put proparacaine in the eye, it's numbing those receptors in a sense and not allowing the signal to be sent down that neuron. All right, so this is pretty cool how we're wired. I kind of just like using the picture here. You can see this person is putting their finger in the fire. Okay, ouch, right? But before ouch, a lot of the times if you've done that, right, you put your hand into a harmful area, you're already pulling back, and then you go ouch. Well, the reason being is because the way we're wired, when those different receptors, those mechanoreceptors, those thermoreceptors, those pain receptors, when they fire, part of it says, hey, you don't have to go up to your brain and say, ouch, and then say, hey, let me take my hand out of that fire and come back down. Those receptors are wired to go to the muscle in your arm to remove yourself from harm. So basically, here's the candle. It doesn't have to go up and down. It goes right in, and it goes right back out and says, get that hands out of there. What are you doing? And then that's why you get that delay at times in that somatosensory cortex where you say, ouch, and your hand's already been removed from the harmful. So pretty cool how it's all kind of wired to when certain stimuli and certain receptors are triggered at certain thresholds, how you're able to get your hand out of that harmful stimulus. And again, it doesn't have to go up to the cortex to tell you to do that. So we have an ascending pathway, a descending pathway, and again, some of the requirements out there had to talk about descending pathways and ascending. So we're covering it here with that slide. So peripheral acting, as you can see from this same slide, this is where the aspirin would work, trying to minimize the amount of substance P. And then central acting, we have receptors that are all throughout our body that are mu, kappa, and delta receptors that then get plugged in by the opioid drugs and then tell the body that there's no pain. So the peripheral acting, again, is the substance P. Those are your NSAIDs and your ibuprofens, and central acting would be more of the opioids. All right, so with that said, we got polling question number 2. So what type of pain does not respond well at all to opioid pharmaceuticals? So which type of pain does not respond well to opioid? Is it nociceptive or is it neuropathic?
And they're off and running, Greg.
Fantastic.
Remember, for everybody, you go to the icon on the right where it says polls if you're on your computer. Click on that, they'll take you to the poll. Hopefully it'll work. Some people were having some problems based upon the chat, but I think we're okay because a number of people are responding.
Fantastic. All right, I'm able to find.
And once we close up this poll, I'll go to the chat and check that out. All right, I think what we're going to do is we're going to close the poll.
And I can see the results. I have them open now. I was able to get them. So, all right. I see 47 nociceptive and neuropathic. So, okay. So nociceptive pain, remember, is pain, right? So the opioids do respond. That's why we use them. We use them for, I guess, if you want to say painful pain, nociceptive pain. Neuropathic pain does not respond well or at all to opioids. So that would be like your post-herpetic neuralgia. So there's, and I got pictures coming up here, but remember, someone could have the infectious part and they could be in a lot of pain. At that point, they will respond to that inflammatory pain to the opioids. But you heal it all, and it's the patient looks totally normal, but they get that post-herpetic neuralgia. That's that neuropathic pain. Opioids and aspirin and Tylenol do not touch that. That's part of the the opioid diversion. Someone comes in and they say, hey, I had that OxyContin for for that post-herpetic neuralgia. That's the only thing that will touch it. Well, not really, because neuropathic pain, that's the tough part about it, is it doesn't respond well to really analgesics that's out there. And we'll talk about that a little bit more. So, the four major types of pain, that's just for this talk. There's all kinds of pain out there, but for this kind of talk, we're going to talk about nociceptive pain, usually to a result of injury. I have inflammatory pain. I showed you that that contact lens overwear, those marginal infiltrative ulcers. That's usually an abnormal inflammation from inappropriate response to the body's immune system. Now, that could say maybe be autoimmune disease, or someone that has an allergy and they're just the immune system is just blowing up on the eye because they have just an over exaggeration to maybe some type of pollen. So that'd be more of an inflammatory. Then we talked about neuropathic pain with the eye. That would be kind of more of a post-herpetic neuralgia. And then there's functional pain. They used to think that was tied to depressions and different things. And does it really exist? And functional pain is there, and that's kind of more of that gut microbiome. That's where 90% of your serotonin, and then when you have leaky gut and gut dysbiosis, you're not getting the serotonin and the brain's not getting it, and then we get some functional pain. So we're learning more and more about these different types of pain. And again, it says four major types. There's definitely more, but we don't have to take a dive into any deeper than those four major ones for tonight. So here's a classic example of nociceptive pain, even though it's spelled wrong there, nociceptive pain. It was hitting my eye with a tree branch, and I think I scratched my eye. So you can see here he comes in, he's got a subconj hemorrhage. But then I was like, okay, what is this? And you can see it looks like there's some conjunctiva. So I numbed his eye up really well, and I went and got a few of the instruments, and he has a conjunctival laceration in here, and I was able to lift that back and then kind of see that, he's got a foreign body in there, and we were able to, in a sense, to take that out. As you can see, I used this like kind of golf club spud or the spatula here, kind of lift that conj, and then I was able to reach in with a pair of forceps and then pull out this thorn, and the sclera did what it was supposed to. I mean, I don't know if it hit directly on or hit from the side, and when it hit, created the laceration for sure. And then the sclera did not penetrate. So he didn't have any choroid coming through. We dilated him. There wasn't any penetrating wound. But he was in a lot of pain. Good news is he missed the cornea, the conjunctiva, cornea being the most innervated. The conjunctiva is, I don't want to say the least innervated, but it's not as innervated as the cornea. So we were able to take out that thorn. He didn't have any problems. We covered him with some Maxitrol ointment, maybe some other steroids. You could see his subconch heme was starting to. You don't really have to stitch the laceration. They usually grow closed on their own, and he was healing up pretty nice. But the point is, he was in a lot of pain, and that was just a nice classic example of nociceptive pain, which responds well to opioids and the analgesics that's out there. So pain is complex, it's confusing. Nociceptive pain, we have neuropathic pain. Neuropathic pain, again, does not respond well or at all to opioids or the ibuprofens. So this is our patient that came in on February 9th, and you can see she has an active inflammatory type of pain. These patients usually come in and say, yeah, my face hurts, I got swelling. This will respond to analgesics. This is a separate type. This is the infectious, the inflammatory type of pain from this patient that has herpes zoster of the ophthalmic division. And then I put her on Valtrex, and you could see she slowly healed over time. And you can see here that she's doing pretty well. I have a video here. I didn't hook up the sound, I guess, whenever I shared. So, maybe I'll stop sharing here and see if I can get connected. If not, I might have messed up total royalty here, and I might have to figure out where everything went. Uh-oh. Where did my sharing go? Guess I should have left it as is. Let's see. Uh-oh. Joe, you're going to have to filibuster here for me. All right, I think I found it. It was hidden. All right, can you see my slides, Joe? All right, I think that was a yes.
Sorry about that. Yes, I can.
Hi, everyone. I'm here with Helen, and as we can see, if you pull your head up there for me, we're just getting over some shingles here, some herpes zoster, and I was telling her about how it hangs out in the trigeminal nerve, and the trigeminal nerves, it's right behind, in a sense, the ear array here, and kind of show me where you were pointing there. You don't have to hold your hair anymore. Just tell me where you're having that pain.
Right here.
Yeah, right in there.
Right
And then tell me about you're having kind of things kind of shoot over. Tell me how you were explaining that.
Every now and then I'll be sitting and I'll get a sharp pain. I have to go like that, my ear.
Yeah.
And there feels like the whole right side of the back of my head feels like a numbing along the base of my neck, all numbing up through here.
Yeah. And that's exactly what, we were explaining is where this trigeminal nerve kind of hangs out. So she's healing up nicely. We're going to get her all healed up here, and she'll be back up and running. So thanks. So, what I'm trying to go with this is, she had an inflammatory infectious, and you can see she's got that tingling. It's that trigeminal nerve. She's kind of moving into some post-herpetic neuralgia, which is not going to now start responding to the narcotics in a sense, or to your Tylenol, ibuprofen. At the beginning, they will. You can make them feel pretty good if they're in a lot of pain when they have the infectious or the inflammatory component. But then as they move into kind of that trigeminal, because remember, this virus is what type of virus? It's a neuronal virus is what it is. This virus is neuronal, and it lives in in this person, it's living in the trigeminal nerve. Now, we all have herpes, right? So I'm not sure where it's living in my body. But, we all got sick one time from a patient. It was the herpetic virus. It just happens to be hanging out in her trigeminal nerve. And then it went down the ophthalmic division and came out as shingles on that right side of the ophthalmic division. and you can see the type of senses that she's having. It's kind of mixed, starting with the pain at the beginning and now moving over to more of a neuropathic pain. So now, not to be confused with neurotrophic. Now, neurotrophic is the opposite. They have no pain, right? And this is from my Oxervate lecture when we talk about Oxervate, Synedgerman. This person over here is more symptomatic and they have less staining. Here's a person over here where the whole cornea is just about SPK, and the patient's like, yeah, my left eye feels fine. I don't see real well out of it, but I don't really have as much pain in it, and that's neurotrophic. That's not good, right? So here is a video of, checking for neurotrophic pain. It's really the left eye. It's an early outbreak of a dendrite on the left eye. But this is a classic case of I take a cotton wisp, I just take and tear it off with my fingernails, and then I just twist a little wisp. And in the videos, I just tell the patient, look, I said, the audience can't hear you because my camera doesn't record, so just blink for me. And this is just checking cornea sensitivity. And you'll see that when I get really close to this eye, and you can see the patient's pseudophakic, and I just hit them with a wisp, just ever so lightly, boom, that cornea is working beautifully. It's not neurotrophic. But over here, I'll pause the video for a second. It's right there that's this early dendrite kind of popping out. And I really wasn't sure. This isn't fluoresce or anything numbing agents in here. And watch what happens with this cotton wisp. I'm literally like carve my initials on this patient's cornea. And there's no numbing drops in here, but you could see what this dendrite, and it confirmed exactly what I thought it was as we do this. But this is neurotrophic now. This is, the patient can't feel it. Before, I just touched them ever so lightly. Here, it's dragging it across. You can see the dendrite-ish there on their cornea. Bring them back in a day or two. It'd be a classic dendrite. We were able to get on top of that pretty quickly. So again, neurotrophic is really the absence of pain. You can see here, this is just another patient. I'm hitting their cornea. They should feel that. They're not blinking at all. You remember the right eye, the other patient, as soon as I touched it, boom, they started blinking. So there's neuropathic, that is pain. That's kind of your post-herpetic neuralgias. This is neurotrophic, where they don't have pain. And then we have our nociceptive pain and our inflammatory pain. So we kind of covered most of those tonight. In that first part. So the drug treatment options for neuropathic pain, we'll cover that real quick. That's not the focus of tonight. It's more of anti-seizure medications. That's your gabapentin, your Lyricas. They're like seizures, so they found out when they gave them for seizure, hey, some of my pain went away. Or Xanax, or Ambien for anxiety. Those are more sleep medications. They have been shown to help with neuropathic pain. So neuropathic pain, we kind of hit it pretty hard with the trigeminal neuralgia and the post-herpetic neuralgia, but you can get diabetic neuropathy. You can get some pain from multiple sclerosis, HIV, tension headaches, migraines. Those are your chronic neuropathic pains. And they're using things like anticonvulsants. A lot of the times you'll see people coming in using Neurontin or maybe even topiramate. They use topiramate a lot for migraines, but also for neuropathic pain. Gabapentin you'll see being used for neuropathic pain. Yeah, I had some shingles on my side and it was really painful, and they put me on gabapentin, and it helped alleviate it, because we now know, because we have to do with diversion and fast talkers and all that. We have to be careful when someone comes in and says, yeah, the only thing that really works on my eye is, Oxycontin. Can you prescribe that for me? Because I have this post-herpetic neuralgia. Now you know that it doesn't really work. And again, there's your tricyclic antidepressants. Here's really a key, right? Acute versus chronic. And when it comes to acute, you could be linear and binary on that. In a sense, if someone came in with a cornea abrasion, we had all these docs in here tonight, and we said, how do you, manage the cornea abrasion? Okay, how do you diagnose it? Okay, I numb their eye, put some fluorescein in there, I measure the size of it, I document it. Okay, now how are you going to treat it? How are you going to manage it? There might be some docs that say I just do an antibiotic, and some docs will say I use Tobradex and Maxitrol, and we can all go back and forth and kind of argue, should we use a steroid? And some people would say, well, if it's vegetative, I wouldn't do it. And, I put a bandage contact lens on, I give them some type of pain medication. We come up with a type of type of paradigm that all of us would kind of fit into. When it comes to chronic things, and Joe heard me say this multiple times at our Detroit lecture recently, it's kind of part of a strategy that's out there. So chronic pain is different than acute pain. Chronic pain and treating pain in acute pain, the goals certainly differ, right? And this is in some of the state associations whenever you have to cover this. So, and this is important because we're usually dealing with acute pain. We're dealing with cornea abrasions or some type of foreign bodies, or maybe like we showed you there, a conjunctival laceration. These things are acute. They're quick. They're going to be healed within a month at the longest, within 7 to 10 days. And the goal for that is to try to keep them as comfortable as possible. Maybe trying to get their pain, if it was a 6 on a pain scale, to a 0 or a 1. Totally different in chronic pain. Someone that has chronic pain, you're trying to get them as comfortable as possible. It doesn't mean pain-free, enough so that they can live a normal life. So, I think most people know I'm a Disney fan, and, there might be, someone that's going on, a Disney trip, and they just had an injury, or maybe they have, they have knee issues, they have arthritis, or they have bone on bone, or they have a hip issue, and, you're not trying to make them pain free. I mean, that would be great if you could, but people with chronic pain, you're just trying to lower it enough so they can go through Disney in a sense, enjoy it. They're not having to sit back at the room, but they still might have maybe a 3 or a 4 on a pain scale, maybe a 2 or a 3, but they're able to walk through the park, do the ride, so on and so forth. So acute, you're trying to get them as comfortable as possible with the minimal adverse drug reactions. Try to get them to a 0 or 1. Chronic pain, whether it's knees or backs or necks, whatever it is you're just trying to get them through their normal life, but they're not going to be pain-free. And remember, chronic pain and usage is where a lot of this addiction comes from. That's why as optometrists, we're not high in the area where we have chronic acute pain. The only time I can really think about it would be like a ptysis bulbi. Someone had a patient and just recently, within the year, had a retinal detachment, didn't want to get it fixed, total retinal detachment, funnel detachment, CRAO, BRVO, whatever happened. Then the eye started to lose its pressure, and it's got like a pressure of 0 or 2, and it's starting to shrivel up. It's a ptysis bulbi type of eye. Then it becomes painful. If they don't want to go get it enucleated, maybe that's a kind of a chronic pain, but you're not going to get them to a 0 in that situation. You're going to just get them down to where hopefully they can live a normal life, or they're going to be doing some type of most likely enucleation with it. So chronic versus acute, the goals are totally, totally different. So pain assessment scales add an objective to the patient's feeling. It does the pain, does the injury or the wound or diagnosis fit the patient's presentation? So pain scales are used when I use them in the practice when prescribing an opioid. So Joe, let's do polling question number 3 here.
Number 3, okay.
Do you use a pain scale when prescribing narcotics? Yes, no, I don't prescribe narcotics, or I'll place a comment in the chat box to make it synchronous.
All right. We're a little slow off the start. I think that was a Zoom issue, but now people are rolling in.
So, do you use a pain scale when prescribing narcotics? Yes, no, I don't prescribe narcotics. I'll place a comment in the chat box. anything in that chat box?
I was just about to look at that now. And the answer is no. People just mentioned there's some quirkiness to the polls. Not everybody was able to respond, but I think we're working pretty well now. And I just made a comment that Zoom, sometimes the platform gets a little quirky, even for us.
Yeah, I built this lecture on my laptop, and I got everything saved to the cloud, and I went up to run this off on my computer, and it just wouldn't download. So I had to resort to a laptop. So, and it's still sitting there not wanting to download. So I don't know what's going on with that. So
All right, well, I think we've got enough responses. I'm going to close and display it. And the majority don't prescribe narcotics. Nobody's going to make a comment in the chat box. But 23% did say yes, they'd use a pain scale.
great. Great. Not, not saying it's right or wrong to do it. I think it does help out if you're going to prescribe a narcotic. I hope the 73% that say they don't write a narcotic, I hope tonight this lecture kind of makes you feel more comfortable. This lecture is kind of more towards the chronic pain. This lecture is, we as optometrists are not creating this addiction that's out there. And these are safe medications.
Hey, Greg.
Tracy Offerdahl and I, what's that,
Greg,
Joe?
hold on. A question came out. I don't want you to get too far advanced, but a question: what dosage and duration would you prescribe gabapentin for post-herpetic neuralgia?
Yeah, unfortunately, that's not on our drug list, even though I've been advocating for it in Pennsylvania. So I don't know that answer because I don't prescribe it. Just for the fact that I don't have that ability to prescribe it. I know certain states do, which is great. Good job to those state associations that have fought and gotten that on there. Joe, do you know that answer by chance, or someone can
I
put it into the
don't.
chat box? So.
I will find it and put it in.
Okay. So sorry, I don't know that one. Usually I do, but it's just I don't have that ability to do that, and I don't know that answer. So the where I was going was when I lecture with Tracy Offerdahl and we chat about these, narcotics are super safe. You talk about ibuprofen. If someone's taking ibuprofen for, it could be as short as a week, 2 weeks. If they're on it chronically, it's not a matter if they'll bleed or get some type of stomach irritation or ulcer. It's a matter of when. In tramadol and hydrocodone or for these eye problems are so easy, so safe to use. This whole addiction, crisis out there has kind of scared a lot of people to using them, and they do become a great tool in the tool belt. And we'll talk about that as we go through here. So, so I don't really have, my office set up with like a hospital bed here where hospitals are always checking, when they come in on, in the morning, late afternoon before bedtime, they're checking pain. I don't really have one hanging on in my room. But I do run two computer monitors at work. And so it's really easy for me to hit pain scale, like I did here, and click on images and kind of just pull one up that's out there. And what the one I like to do is, it's got colors on it. I think we all know green is good and maybe red is bad and yellow is kind of in between. And people know 0 to 10, or people like to read. Some people like to read a little bit more. So this is the one I usually try to find whenever I Google, as you can see here, pain scale, instead of where this is all kind of the websites. You just click on images and then go and click on, like, boom, right there it is. And then, just say, look, I'm going to prescribe this tramadol for you. And really, here's my Pavlovian response. When patients come in and they've had some type of trauma to their eye, and maybe they've been up for, maybe they've been suffering for it over the weekend. Oh, we didn't know you were open. We waited till Monday, and it's happened on Saturday. And they're like, man, all I need is to get a good night's sleep. And I'm like this, what? Did you say good night's sleep? Because what's one of the, if you want to say adverse, I don't think it's an adverse event, but what's one of the side effects of a narcotic? It makes you drowsy. It puts you to sleep. So when someone says, I need a good night's sleep, if I could just, I know if I can get like a good night's sleep, I can knock this off. I'm like, ding, 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 ding. What'd you say? Good night's sleep. And that's, tramadol, that's my hydrocodone. Those are your Lyricas, 5 milligrams with some acetaminophen or 50 milligrams of tramadol. And they'll just take that pain away and create that sedation, maybe for that patient, just to get over that hump, to get that good sleep. And we know that sleep is important and will help in many ways for the patient. So that's really my key. I don't look at my room set up like this. I just go to Google, I hit pain scale, and I say to the patient, okay, where are you on here? Are you 1, 2, or 3? Where are you? And really, the drawback to the pain scale too is, a 4 could be different than a 6. So I got some paradigms coming up here when it comes to help in managing pain and using pain scale. So the combination pain scale is the one that I typically use. Again, I don't have it hanging in my room. If I'm going to prescribe, the patient was a 6 on the pain scale, and I just go right to the internet and just pull it right up.
And
All
actually,
right.
Greg, going back a little bit about gabapentin, it
Yeah.
looks like the best dosing is 600 milligrams, which would be 200 milligrams 3 times a day for the first 3 days.
And that's for the neuropathic pain that's out there. So sounds
Post-herpetic
like,
neuralgia.
yeah, post-herpetic neuralgia, neuropathic pain, 200 milligrams. Sounds like TID for, yeah, the question. That seems a little short, but, again,
Well,
I don't have
that's when
experience with it.
the main relief comes, but it'll go for 7 to 10 days.
There we go. Perfect. Thanks for looking that up.
No worries.
So let's get back to nociceptive pain, right? This is an inflammatory pain. This isn't neuropathic, neurotrophic, functional. We're talking, I guess, if you just want to say pain, right? You have a trauma, you have pain, in a sense. So we're talking the groups of analgesics. You have your non-opioids, which would be your acetaminophen. Then you have your NSAIDs. And then I think we forget like methylprednisolone, your Maxitrals, your Tobradex, right? These patients usually come in with these non-specific, conjunctivitis, inflammatory conjunctivitis, and they usually have like pain, right? My eye hurts, it's red, it's inflamed. So remember that I think we forget that if anti-inflammatory or steroids in a sense can fall into that analgesic category. I think we put them into the anti-inflammatory category, but I think we forget about the analgesic side. And then your opioids, codeine. I've never really found it to work with great for eye pain. It's on a lot of formularies out there. There are a lot of state associations, so we talk about it. It's really the hydrocodone, the Vicodins, the Lortabs, or the Ultrams or Tramadol. That's where, if you want to get a clinical pearls, of the 73% that weren't using narcotics, maybe don't have a DEA license, so you can't prescribe. Remember, you have to have a DEA license to be able to prescribe narcotics. But if you have one and you're not prescribing them, I would encourage you to get comfortable with hydrocodone, get comfortable with tramadol, because they do become very helpful in the clinic with some of these traumas that do come in. So, polling question number 4, marijuana is allowed to be used in Colorado as recreational usage. Is it still considered illegal by the FDA in Colorado? So they voted to be able to state versus the federal government, and they said, federal government, leave us alone. We're going to do this here recreationally. There's other states that do it, but I think Colorado was one of the first. Is it still considered illegal by the FDA?
Well, they're responding. All right. Somebody put in a nice tip for the polls on how to make sure they can respond. I like that. Very good.
What's the tip?
Well, the tip is when the poll comes up, be sure to tap on the next poll number.
All right.
So you have to scroll down and tap the latest poll number. You know, actually, I never attended one of these doggone things, Greg. We always just run them.
Yeah, that's what. Thanks for the input. I always say traveling's a team effort, and so is taking CE online. So, thanks for that input. For whoever helped out, whoever made that comment. Thank you.
Okay, I'm going to close the poll and display it. 80% said yes, 20% said no.
Yeah. So the 80% poll, phone your friend or poll the audience is correct. It's still considered. All drugs like marijuana are considered illegal. Heroin, so on and so forth. But marijuana, we're talking here, is illegal and still considered illegal by the FDA. It's just that in that state, separation of federal and the state is that they leave it alone. So my point is that's why, it's when I walk through the Colorado airport or Denver airport, they always have the dogs out there sniffing. They always got someone grabbed up, and because even though they're the airports in Colorado, and maybe someone's trying to get some gummy or something back or whatever they're doing. As soon as you step on that federal property, it's you're back into the federal type of rules that are out there. So it's still illegal, considered by the FDA, but they leave the states alone in a sense. So. All right, so controlled substances, schedule number one, heroin, marijuana, LSD, mushrooms. Really, there's really no medical benefit in a sense. Now, marijuana, there is medical marijuana, but the heroins, the LSD, the mushrooms, fentanyl, that type of thing, illegal fentanyl, those are all Schedule ones and maybe used in research, but certainly not used in medicine other than the medical marijuana. And then as you go down through, so one are in a sense, the most addictive, Schedule two, getting less addictive, three, four, and five. And you can see here that, Schedule two, that's your hydrocodone and Vicodin. And we'll talk about that here in a second whenever, we always talk about being able to be legislative out. That was a kind of a classic. Good news was it didn't really impact us, but morphine falls in here, hydromorphone, your methadone fall into Schedule 2. Schedule 3, again, theoretically safer as compared to 1 and 2, less likely for abuse compared again to 1 and 2. Schedule 4, you're getting into safer, less likely for abuse, again, compared to, 2 and 3. And here fall your diazepams, which are your benzodiazepines, your sleep agents fall in here, your Ambiens, and your tramadol. So tramadol used to be left up to the states, and then moved to Schedule 5, which is your codeine that inhibits the cough that's out there. But it did have a little bit of abuse. The I guess the addicted person, they call them trammies. There is a little bit of a high that you can get from them, but certainly not like OxyContin and some of the other ones that are out there. But they did, I guess they do have some street value, if you want to say. So state by state restrictions regarding the marijuana, but hydrocodone, that was in 2014, 11 years ago. Whenever in Pennsylvania, it was a category 3. And when we passed our legislation in 1996 or 90, 96 or 97, but we didn't get the regulations through until 98. We were able to we got everything except glaucoma and steroids. We got narcotics and all the oral antibiotics, but we didn't get steroids and glaucoma. That wasn't until 2002. But we got our narcotics, and we had, within there hydrocodone. And then in 2014, it went to Schedule 2, and I used to use that medication. It was great. Tramadol and hydrocodone. Codeine didn't really work so well, and there's a case where we were legislated out in a sense of our profession with a move. So opioids, kind of known as narcotics, mainstay of therapy for the treatment of pain. No, here's really some of the kickers where it starts to kick in. There's no maximum daily limitation. And where I'm going with that is I'll go with ibuprofen. Ibuprofen Prescription strength is 800 milligrams. Over the counter, you can get 200 milligrams. So if I take 200 milligrams, I get some anti-inflammatory. It's mainly analgesic. And then if I take 400, I get a little bit more of anti-inflammatory, not much, but it's still more analgesic. And then you get the 600, you start getting, the anti-inflammatory, and you get more analgesic. And then when you get to 800, that's you're getting your maximum in a sense of the analgesic, and you're getting the anti-inflammatory. If you give 1,000, you don't get any more analgesic effect. You could take it. I mean, it might cause other harm, but you're not going to get any more pain. So there's a ceiling in a sense to ibuprofen. When it comes to opioids, there's no maximum limitation. If you do 50 and you become tolerant, you can give 75. And then if you become tolerant, you can go to 100. Now I can just keep going all night because, again, there's no maximum daily limitation to these. They're useful, again, for acute, and that's where we're going to be living, and chronic. They mimic the endogenous opioid compounds, the enkephalins, dimorphins, and your endomorphins, right? So we all know the people that run marathons and they get that runner's high, they get the endorphins running, and they get that kind of high feeling. That's your endogenous, your body making these dimorphins and endorphins that are out there. And that's what these opioids that are found in nature, they mimic. So the mechanism of action is they relieve pain by inducing a euphoria by binding to the receptor. Again, and the receptors are mu, kappa, and delta. I think I said gamma earlier, and I was wrong on that. Mu, kappa, delta are the receptors that they plug into. Now, here's the key is that mu, when it plugs into, if you look, mu, kappa, delta, analgesic, analgesic, analgesic. When you plug into a mu, you get a euphoria. So when people take these medications and they get like a chill, okay, I feel pretty good. That's normal, right? That's not you becoming addicted. It's because your mu receptors are being plugged into. You get meiosis, there's the sedation, the constipation comes with it. We'll talk about that here in a second. You get the cough suppression, right? The respiratory depression that's out there, and then potential addiction. When it comes to the kappa, analgesic, you get sedation again. That's why we like it. For the people who say, ding, 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 if I can just get a good night's sleep, man, do I got a deal for you. We got some hydrocodone or some tramadol coming on board, but a dysphoria. And I remember Tracy one time, she couldn't wait to call me. The story's probably now about 6 years old, maybe a little bit longer. She called me up. She's like, I got something to tell you, because Tracy is the pharmacist. You've probably seen her lecture with us before at live meetings. We've had her for webinars, and she's talking about a patient that came in, and she does chronic pain management in her apothecary. And she was working with, adjusting. You kind of have to do some tricks and move things around. So because there's a ceiling effect, there's no ceiling effect with these, but you could shut down their respiratory system is the problem with these medications, and that's not good because when you can't breathe, that's when people die. So she was playing around with it, and a patient came in and said, I had Mickey Mouse chasing me with a cleaver. Right? She couldn't wait to tell me that story. That was a dysphoria. So that's dysphoria from kappa. You got euphoria from your mu. And then you have delta, which is just all analgesic. So people would say, well, geez, just make drugs that just plug into the delta. The drawback is the mu receptor is the driver. So you got mu, kappa, delta. Delta doesn't put a lot into to really helping out with analgesic. It's really the mu and kappas that cover it. We don't have a ton of delta receptors all throughout our body. And this is my favorite slide. It just kind of shows you that these mu, kappa, delta are found all throughout the body. And that's why whenever take an analgesic and it plugs in, say, to the ones in the intestinal tract, is that you get constipation. If it plugs into the breathing centers, you get that decrease in respiration that's out there. Now you do get the decrease in pain. You do get some brain and brainstem side effects also. But I love this because it shows that these receptors are found all throughout the body, and that's what creates the issues. And again, mu is definitely the dominant in helping out with controlling pain. I wish we had some more delta because they really don't have that many side effects that's out there. When it comes to opioid drugs that bind to the receptors, you have your opiates, which are morphine and codeine. You have your semi-synthetic, which is your oxycodone, and you have your synthetic. And I always like, and maybe I should have made this a polling question, but you can just ask yourself, there's no polling question. What are you most likely allergic to? Things that are more found in nature or things that are synthetic? And the answer is, I'll let you kind of think about it. Is it more the natural things or is it more the synthetic things? And the answer is the natural things, right? They're found in nature. We have a more likelihood of being allergic to it. So that's why maybe morphine patients could be allergic to it, but maybe not an Oxycontin. Or if they are allergic to the opioids or the opiates, then you can go down into your fentanyls, your methadols, and look, tramadol is good because it's different. It's not really found in nature. So really, that's why I live my life in a sense on those 6 to 12 patients a year using hydrocodone in the more severe case and tramadol in the less severe cases. And if they have an opioid, I can jump to a synthetic like tramadol to help manage their pain. And here's a nice little kind of graph over here, just for you to kind of flow through. I'm not going to go through it during the lecture, but these are all kind of your opioids. You have your cannabinoids, your opioids, your cocaines, and how they plug in, and you have your natural, semi-synthetic, synthetic, and then your endogenous opioids. All right, so formulations. When we're prescribing them, we're going to want short acting or IR, which stands for immediate release. We don't want the ones like this, Oxycontin or Oxycontin, which is oxy continuous release. We don't want morphine sulfate, which is continuous release. Those are for your chronic pain patients. If you're going to prescribe, you're going to prescribe a Vicodin. You don't want a Vicodin. I think it's like ER or EX, extended or extended release ER. You want Vicodin, Tramadol, Percocet. You're doing acute pain, so you want it released. We're not doing slow drips to try and get the patient just enough so that they're not gorked out and they from being on it, sedated. What I mean by gorked out. At a high dose where they can't function, it's just enough to get them past to live their everyday activity. They're still going to be in pain, maybe give it at a higher level and a quick release, again, for those patients to say, man, I just need to get a good night's sleep. So morphine, that's where it kind of is the standard for comparison. You'll see as we go through that they'll compare it to 30 milligrams of morphine. It's the comparison used for severe pain. And now I've never prescribed morphine, but if someone came with a corneal abrasion, we would do morphine sulfate immediate release every 3 to 4 hours. We wouldn't want to use the CR or the continuous release when we're treating acute pain. Those would be more for that chronic pain. So again, another reason to know acute versus chronic when it comes to these, because we don't want the extended release ones. If you're going to use hydromorphone for or Dilaudid, which is great, it's a super strong. And if you look at the comparison, 30 milligrams of morphine, it only takes 8. Super potent, used for severe pain. I don't think any of the states, maybe Oklahoma, has the ability to do 2 through 5, but very rarely are we going to be reaching for Dilaudid because that's more for severe pain. But you can see 8 milligrams to 30 of morphine. So when it comes down to the codeine based, codeine is natural. So that's why a lot of people are allergic to codeine. And then you start getting into semi-synthetic, and this is the one that I use a lot for patients but it's a category 2, but our state was able to get that hydrocodone fix, if you want to say. And it's a semi-synthetic derivative of codeine. It's definitely more potent. I have tried, Tylenol 3 for eye pain, and it just doesn't seem like I just might as well just give Tylenol and some ibuprofen. It just doesn't give that good analgesic type of effect that you can get with tramadol or hydrocodone. And again, it retains its cough suppression. So I have oxycodone down here, and I have this highlighted in red for no cough suppression, right? Because this is a course not only to make you feel comfortable or help you feel comfortable, not make you, but help you feel comfortable with opioids, but it's a also, watch out and diversion. And, every so often it happens, someone comes in and, I'm not sure if this has ever happened, but this would be kind of an example that you're looking for. Hey doc, I have this cough, and the only thing that really can suppress it, it's not codeine, it's not hydrocodone, it's that oxycodone it's in there. It's I got a really bad cough and I need to suppress it. Well, that's so semi-synthetic or changed that it loses that part of the molecule that suppresses the cough. So there's no cough suppression with oxycodone, but you do retain it with your hydrocodone and then definitely, cough syrups with codeine. You get that respiratory, shutdown, but you don't get that cough suppression with the oxycodone. So you can see here, Tylenol with codeine, Tylenol 3, it's basically the best ratio. Whenever you have 300 milligrams of Tylenol or acetaminophen and the 30 milligrams. So you could give 2 of these and you would get 660 milligrams. You get 300 of, you get 600 of the ibuprofen, I'm sorry, of the Tylenol, and you would get 60 if you would double if you take 2 of the codeine. And you could get the same 60 here with Tylenol 4, but then you would only be getting 300. So Tylenol 3, in a sense, why is it always prescribed? Is that it's the best ratio. If you try to get 60 milligrams up here, you have to take 4 of them, but then you would be getting too much Tylenol or the acetaminophen. So in a sense, it comes down to it's the best ratio. Pharmacists don't even carry Tylenol 2 or Tylenol 3 in the pharmacy. All they do is, carry Tylenol, or 2 and 4 they don't carry. They carry Tylenol 3. So if you're ever going to prescribe it, do T3 or Tylenol 3, 300 slash, 30, and, 1 or 2 tablets every 4 to 6 hours. I've tried it multiple times. I just kind of steer away from it because I've never had a huge success. It does lower it, but, we're trying to get these patients comfortable, trying to get them a good night's sleep. It might knock them out a little bit, but it doesn't take away the pain, and maybe the pain keeps them awake. So again, tramadol and hydrocodone are the ways to go. So your oxycodone products, they're definitely strong. You have the long-acting Oxycontin. You have immediate release. If you were going to use it for eye pain, you'd want to use the Oxy IR so that you do get that pain coverage, and you would help put that patient to sleep with the sedation. You can see it's not as strong as hydromorphone, but it's stronger than morphine, where it only takes 20 milligrams to get that same equivalent of 30 milligrams of morphine. And remember, they use morphine as kind of the comparison when it comes to the medications. So here's hydrocodone. Again, August of 2014, it was changed from a category 3 to a category 2. And that's what happened in Pennsylvania in 2014. I used to use it and couldn't do it. And whatever year it was, 2018, 19, we were able to get that. So for 5 years, I had to stay away from it because it wasn't within my, it was at one point, and then it's not. So now it's back in. So I do like having it as the ability to be able to prescribe it. And basically, hydrocodone is just mixed with Tylenol, acetaminophen. They do have an ibuprofen product, Vicoprofen. Yeah, I don't even think they keep it in the pharmacies. No one really prescribes it. If they're going to do it, they always use it with the acetaminophen and hydrocodone. And I think we know the Vicodins and the Lortabs. And you can see it's pretty much all the same for these. Norco has 325 of the acetaminophen or Tylenol, but you can see it's 5 or 7.5 or 10 milligrams of the hydrocodone, and Lortabine goes low as 2. Pretty much eye pain will respond very well to 5 over 300. So you prescribe 5 over 300. Usually I do 8 or 10 type tablets. It's basically 1 or 2 tablets every 4 to 6 hours for pain as needed. And again, there's a cutoff for APAP or acetaminophen or Tylenol. It used to be around that same time, 2014, so about 11 years ago, you were allowed to take 4,000 milligrams or 4 grams a day. But because of the alcohol and the liver damage, they lowered it down to 3 grams. So you could give basically 10 tablets of pretty much Vicodin or Lortab a day, because remember, there's no really ceiling effect to the hydrocodone. So if you gave 5 over 300 or the 5 milligrams of hydrocodone and the acetaminophen, you could give 10 tablets just out of zero. Tell them to take two tablets 5 times a day. They're not going to need that much. For eye pain, they'll take 1 or 2 tablets. 2 or 3 times a day, maybe on the first day, and the next day they're probably going to be healed up enough that they'll just take 1 or 2 tablets just a couple times throughout the day. So usually, 8 to 10 tablets is enough to get the patient through. Now, could they become addicted to that? Absolutely. Not going to say it away. Is it likely? Very unlikely. I've prescribed enough over the years. I don't think I've created any addiction issues for the patient. So again, I don't want this lecture to be a negative lecture for those that aren't prescribing, that do have a DEA. I want you to feel more comfortable because we're dealing with the acute pain, not the chronic pains. So here's my favorite right here. This is like, optometry's, narcotic for treating pain, tramadol. It's a dual acting. It works on the serotonin reuptake. So you got to be careful if someone's taking, Prozac, sumatriptan for migraines, because it does inhibit the neuronal uptake. They're already on serotonin reuptake inhibitors. They could get maybe too much. Every time I've called the PCP and said, hey, I got a patient here with corneal abrasion. I know that this inhibits, and they're on sumatriptan, they're on Prozac. They're just like, look, it's only going to be for a couple of days. You're not going to mess anything up. Go ahead and use it. So I guess, from the acute standpoint, you should feel pretty comfortable using this medication. Pretty much I do tramadol, 10, 12, try to calculate out, how many they're going to take. They're going to take, 2, maybe 3 times a day for the first day. So they're going to need 6. Maybe they'll take 1 3 times a day for the next day, 9. Maybe they'll do that again. So, 10 or 12 tablets over, 1 to 3 days, depending on the injury that they have. They do make one that's an extended release right here, tramadol ER extended release. Make sure you don't prescribe that. I was in a lecture one time listening, and they're like, well, the lecture was, maybe they got confused, and they were like, oh yeah, everyone prescribes this tramadol with Tylenol. And later that night, I called Tracy up and I said, hey, am I missing the boat on something? She's like, oh, I did a lot of chronic pain. It's not prescribed that much. Maybe they meant to say tramadol, but pretty much all you're going to do is just tramadol without the acetaminophen in it. When it comes to hydrocodone, when it comes to Vicodin and Lortab, yes, you're going to use it with the acetaminophen. That's really the kind of the synergistic effect, the boom boom. But when it comes to the tramadol, because it's already kind of got this dual action, you're just going to do 50 milligrams tablets of Ultram. 12, as we discussed how we got there, and have them take it, 1 to 2 tablets every 4 to 6 hours for pain for their treatment. So really, that's your 2 right there in eye care. If you have a DEA license, I'd encourage you to reach for it. All right, so let's do this polling
All
question.
right,
When you
polling
see
5.
a patient in your office on methadone, be kind to them because they are trying to recover or have recovered from an opioid abuse. So I guess the question to summarize it is every person using methadone coming into your office recovering or were addicted to opioids at one time?
All right, they're coming in, Greg. There's nothing in the chat at this point. Okay, I think we're.
And not to let the cat out of the bag, because I see the answers rolling in here, I kind of felt this way until I was taught that that's not true. So I see that 63% of the audience is 62% is saying, yes, they were probably addicted, but it's not. Remember that methadone can be used for pain, especially if someone is allergic to an opioid. Some of the remember these are synthetic, and so someone could be allergic to the opioids. You can reach for methadone. So
Greg,
there's
you can actually interpret the responses a couple different ways. I look at it, 62% said you should be kind to them, and 38% said you should not be kind to them.
yeah.
I
Guess I
guess,
need to
I guess,
reword my.
I guess that's one way to look at it. Don't be kind to them.
So, yep, that's a good way. All right. So, the miscellaneous ones that are out there, fentanyl, it's a great analgesic. It's the most potent. It has a black box warning. So used medically, it's a great pain, compound fractures, so on and so forth. It's the illegal stuff coming across the border that just is just, it's been, laced and potent and it's deadly. That's why we hear, sad stories all the time from that. And, we're talking about methadone. Here's really the trick when it comes down to, it can be used for chronic pain or it can be used for opioid abuse, um, um, for addiction to try and help them to recover. And here's really the key. If they're using it twice a day, then it's likely that they're using it for pain, right? So they're taking it, it's plugging into the receptors, and it's taking it twice a day. The once a day is they're just trying to tickle those receptors just enough to help take away the abuse. So if it's once a day, dosing, and it doesn't mean it 100%, but it's usually they're usually trying to recover or just trying to stay away from the opioids. If they're using it for twice a day, they're just trying to keep that nice basal steady rate from day to night while they sleep. Take it in the morning, just trying to keep that nice steady amount of analgesic to help the patient not have that pain and deal with that chronic pain that we talked about. There was a lot of this in the news recently, about, pregnancy and analgesic, and it still kind of holds true in a sense. Try to take nothing. If you need to do something, consider Tylenol. Stay away from the NSAIDs, obviously stay away from the opioids. Try and stay away from everything, but there's times whenever, someone that's pregnant is going to need something and, try to management with as little acetaminophen as possible. So it's really the choice in pregnancy. Opioid allergies. If someone takes, if a patient states, codeine allergic, ask the appropriate questions that's out there because here's the key, right? You saw me, heard me talk about these outcome things and everything's connected. And as soon you might be Dr. Zero in a sense that, oh, the patient reported they're allergic to oxycodone, and you put it in there, and now we're connected, and it goes through all the health systems, and they might not be allergic to to these opioids. The key is sometimes it happens, after surgery. Someone's given an opioid IV, and then they have a reaction, and it's because of the histamine release. It kind of keeps it sequestered, and the histamine is trying to release, and then all of a sudden it wears off, and then they get a big histamine reaction, and it looks like they're having an allergic reaction. It's nothing more than these little red splotches that occur. That's not a true allergy. That's just a side effect of what the opioids do, and kind of suppressing, and then kind of a surge of histamine that occurs. That's not an allergy. So I always just be careful with reporting allergies. Try to really ask the right questions that are out there. But if they are allergic to opioids, that's where your fentanyl, your methadone, and meperidine come into play. Just watch out for those strange allergies. Remember, this is an opioid diversion course too for the states that need it, for the docs that need it, and watch out for those that have those strange allergies. And oh man, I'm allergic to everything, but I'm not allergic to fentanyl that's out there. So just watch out for that fast talk. I talked about the using the numeric pain scale, and this is kind of what Tracy and I sat down. She's a pharmacist, but she's been teaching at the school for many years. We've been lecturing together. She understands, optometry and in the eye and pain, and she sees it in her clinic. So we just kind of sat down and using the pain scale of like 1 to 3 here. You could probably get away with Tylenol if it's a 1, ibuprofen and Tylenol. Maybe if it's a 2, again, a lead falls into there. But again, the pain scale is big. You get a 3. A 3 might need a 50 milligram once a day, or one at a time, not 2 tablets, but 1 tablet. Maybe 1 to 3 times a day. Maybe a low dose tramadol if it's a 3. But a 1, you're not going to need a tramadol. But now you're getting the 4 to 6, and now you have 4 to 6. You're going to probably go to tramadol maybe 2 every 4 to 6 hours. Tylenol with codeine, we threw it in there. Again, I've never had much success. This is on a pain scale elsewhere in the body that might work well. Now you're getting into your acetaminophen, your Percocets with oxycodone, or your Vicodin low dose. Your 5 milligram and 300 of the acetaminophen, maybe 1 tablet, 3 times a day. And then when you start getting into the 7s, you might be taking, 2 tablets, 3 times a day. And then you're getting into your Oxycontins, your morphines, when you start getting up into those 8s, 9s, and 10s, right? You might have a ruptured globe, and someone might need to have, Dilaudid or fentanyl or morphine because their eye is in so much pain. Luckily we don't see those. We're just dealing with tramadols and hydrocodones, the Lyricas, and the Vicodin. So we just put together a pain scale of kind of how you would maybe step through that if you had a pain scale and started using one. All right. We kind of chatted about this a little bit, but let's go back to it and revisit it in a polling question to help make it synchronous and interactive. One of the main problems with an opioid is it the low ceiling effect, the high ceiling effect, or the lack of a ceiling effect? Which one is it when it comes to the opioids? Is it low ceiling effect, high ceiling effect, or a lack of a ceiling effect?
All right, they're off and running, and we're still good on the chat.
Fantastic.
Okay, they're rolling in. They're still responding.
It looks like the trend is set. So
Yeah.
we're So I see that we have low ceiling effect, which is 16%, 29 is your high. And then again, polling the audience, it's the lack of a ceiling effect. Remember, your ibuprofens, your Tylenols have a ceiling effect, whether it's high or low, they have it. and the opioids do not have a ceiling effect. So that's really the part of the problem, right? When people become addicted. And what happens is when they become addicted, they want to get that euphoria, right? They want to get that mu kappa plugged into, but they're becoming tolerant. And so now they need more. But now what's happening is we're plugging into that respiratory system. That respiratory system can only take so much plugging in till someone stops breathing. And it's really when you talk about the Narcans and you see it in the movies and they squirt it up the nose, the patient literally wakes up from that. And again, the central nervous system agents, your opioids, no ceiling effect, peripheral, have a ceiling effect. So again, your ibuprofen prescription strength, 800 milligrams 4 times a day. That's all you're going to get. You're not going to get, if you take an extra one or if you take 1,000, you're not going to get much more analgesic effect when it comes. So tolerance, it's the escalation of dose to maintain effect. Now, that could be to get analgesia, right? So someone's taking tramadol, 25 milligrams. It doesn't really come in 25 milligrams. Maybe they're cutting in half, but now they became tolerant to that. So now they take 50. They become tolerant to that. Now they take 75. They become tolerant to that. You can keep giving it higher and higher, but now you got to be careful plugging in. So it could be someone trying to do it to get the euphoria, right? That addiction side. It happens to everyone, right? It happens to those who drink alcohol. Every so often, I'll quit drinking for 3 or 4 months just for just want to do it, just stay away from it. And, I'll go and have a beer and I'm like, wow, whoa, so I lost my tolerance that's out there. It happens with alcohol, it can happen with opioids. So regarding the euphoria, it could be life-threatening because respiratory depression does not show much tolerance to that. So anytime I prescribe an opioid, you want to prescribe Senna S with it. So constipation is going to happen when you take it. So even if I prescribe it for 3 days, I say to the patient, look, it's going to slow down your digestive system. You're going to become constipated. Make sure you get Senna S. And Senna S, the S is stimulant. And I wish I could take credit for this, but Tracy is the one that I heard her say is, look, you don't want the mush, you want the mush and the push. So you want to make sure that you're taking and softening the stool. That's the Senna, but the stimulant is moving, the stool along. So you just don't want to give a stool softener. You want to give that stimulant so that the patient does not become constipated. Again, the side effects are sedation. We talked about the euphoria, the dysphoria. You get the histamine release that can cause the little red splotches in your skin. You can get nausea. It can plug into the to the vomiting zone in a sense, the chemotaxic zone, the hydrocodone, allergy. Be careful with those that are out there. Confusion, meiosis. Again, the respiratory, but that's why you got to be careful when you're using this. Make sure they're not drinking or on benzos or muscle relaxers, right? That's what happened to our singers, Prince and Michael Jackson. And I'm not really sure. Probably Elvis. Never really looked into what he was doing, but I know it was a high and a low, and the same thing with Prince and Michael Jackson, with the sleep, with the different types of medications that we're using. And, it just gets plugged into the receptors and it just shuts down those breathing centers. And, obviously if we're not breathing, then the person can die. The withdrawal symptoms that are out there, short half life agents are more likely to cause abrupt withdrawal symptoms, sweating, agitation, irritation, irrational behaviors. Again, it's the respiratory. Remember, they do inhibit cough, but if you take too much, it just inhibits the whole respiratory system. So just remember that as a reminder. They do have cough suppression. Oxycontin doesn't, but they do shut down the breathing centers. And this is why Oxycontin, or this is why Narcan works so well. If you look at morphine and you look at Narcan, these two molecules, luckily Narcan has a stronger magnet, if you want to say, the stronger attraction between the receptor and this molecule. So when the morphine or the opioid is sitting on the breathing center and the patient can't breathe because it's being blocked because it causes respiratory depression, what happens is when they squirt it up the nose and it gets into the bloodstream, luckily it says, "Hey, opioid, boom, get off of that. I'm stronger." And the Narcan doesn't have the respiratory depression, and it causes the patient to breathe, just like we see in the movie, and they wake up. And so that's how that medication works, because luckily it looks like morphine and it can plug into the receptors, but it's strong enough to knock it off. And the drawback is when someone is addicted, we're going to talk about that. Despite harm, they'll keep doing it again, and they want to have that high because they're addicted, and they'll go back and do it again. As part of the treatment, as they came up with trying to mix the antagonist and the agonist together, it really wasn't a great success. They do make some of them that do have the Narcan in it, but it's not that successful in trying to help the patients from this. So they have different types of morphine, again, with the Narcans, not really has been a success out there. You want to look for substance abuse history with patients. You want to be careful prescribing, anything that a patient might have some type of record, even tramadol, you want to stay away from if they have some type of addiction. True addiction, formerly known as we used to hear that, oh, they're psychologically dependent. We don't really use that anymore. We do true addiction when we're talking, and it's, really 4 words: compulsive despite harm. So again, someone was given Narcan, they're back on the street again that night, and they're already looking for, a way to get high or to get those receptors despite the harm, despite that they could die, or they're reaching into razor blades and glass just to get 2 or 3 tablets of Oxycontin. So compulsive despite harm is really a 4 word, and it covers, the what we need to do for the regulatory for the board. So you have to talk about true addiction that's out there. Identify the behaviors of abuse and addiction, fast talkers, strange allergies. Man, I have this really strange allergy, and anything that really works is Oxycontin. Lost meds, craziest thing in the world. It's the 3rd time this week. They flushed down the toilet, and then I was on a plane, left them on the plane. Da 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 da. They always have an excuse. So just be careful that are out there. Every so often, maybe once a year, I get something that, into the office, maybe once every other year. But Tracy always has some really good stories as a pharmacist of her fast talkers that come in. She'll call me every so often. She'll like, wait, do you hear this one from today? Try not to get bullied, but again, try not to judge the patient. I have one where I was kind of judging in a sense, and you'll see I have a picture of it. I really wasn't judging, but I was like, this really doesn't make sense. All states have a PDMP, a prescription drug monitoring program. I have an Oklahoma license. There's one for Oklahoma. I have a Pennsylvania license, and there's how you log in a sense. Here's my 2 cents on these drug monitoring programs. Is log into them tomorrow if you want to use them. They're state run, they're security, they need to verify you're a doc, so on and so forth. Because if you ever want to prescribe it and you want to check, you don't want to be sitting there trying to log into the database. So I have it saved on my computer. I can log in. And what I do every so often, if I see someone on an opioid at lunchtime or at the end of the day and I see they're on it, I'll just go in and type their name in and the list will come up. So just kind of get used to it. So get used to using your prescription drug monitoring program. If you think the patient might be trying to fast talk you, when they leave, go in and log in. My point with this, my clinical pearl is they're not the easiest. The state websites are not always the easiest to navigate. They take a little bit of, getting used to. get into it. You're a licensed doc. You don't have to have a DEA number to be able to log into these, but you want to be able to log in and take a look around. Type your name in, type of patient that comes in that's on an opioid, and you'll get to see what it looks like. And every time I do a tramadol, I do log into this. So you want to, don't want to be trying to set it up for the first time. So my poll is just do it sometime this week so you can get used to it and how to use that. All right. So how are we going to combat abuse? What they tried doing for things like OxyContin is that, the original formula could be crushed. They tried putting a gel around it. They tried getting it so that it couldn't get into the syringe to be injected. It would be kind of clogged up. But, if you're addicted, you're going to find a way to work around it. And, you can Google it. And some people were putting, rubbing alcohol in their mouth. Okay, there's your, compulsion despite harm. And you're putting out rubbing alcohol and getting the coating off and then letting it dry and crushing it up. And now you're getting rubbing alcohol into your body. So, there's ways to try and get around it from the drug companies. Now, from our standpoint, what can we do? We could do things like NSAIDs and COX-2 inhibitors and corticosteroids. 92071, you can get, try and get paid for it. Some insurance companies cover it. We can do bandage contact lenses. We're going to do the alternative part here real quick. You can use bandage contact lenses. I keep plus a quarter, minus a quarter, night and days in every room that I work out of, because I can always put a bandage contact lens on. We talked about your corticosteroids, methylprednisolone, a Medrol dose pack, 21 tablets, 4 milligrams. I do that quite a bit for our contact dermatitis. But again, that's kind of a form of a pain, so we can use that. Millipred, a lot of people would ask about that. No one really uses it, so that's really the summation. If you're going to do it, it's a Medrol dose pack, not prednisolone, a Millipred. So anytime you're using steroids, just be careful. It can interact with, other medications and glucose control. We're only doing it for a short period of time. Acetaminophen is a great analgesic along with ibuprofen. I'm going to click through here to get to this right here. When I prescribe, and I can prescribe a lot and cover a lot of pain with this, 2 and 2 or 4 and 2. A lot of the patients are like, oh, that seemed like a lot of pills. So I took 2 and then I waited a couple of hours and took another 2. I have to write it down, and I say, look, take 2 ibuprofen, that's 400 milligrams because it comes in 200. Take 2 500 Tylenol, it's 1,000. You're going to take 4 pills, take it all at the same time. If it's something inflammatory, like a trauma, I want to get some anti-inflammatory, I will tell them to take ibuprofen 6 pills. Don't space them out. Swallow them. Don't take all 6 at the same time, but take them at the same time in a sense with lots of water. And that has shown to get to the level of morphine. 4 and 2, 4 ibuprofen, prescription strength is 800 milligrams. So you can give them, just tell them to get Advil at the pharmacy and take 4 of them, or you can write a prescription for 800 if they just want to take a big tablet. 800 milligrams, 1,000, and you take it, it gets to the level of morphine. It just doesn't stay there as long, and it comes back down. So that is a nice little trick that I do. 4 and 4, I'm sorry, 2 and 2 or 4 and 2, and you can cover a lot of pain with that. All right, I'm going to go through the CBD pretty quickly here. It really hasn't been found to be much helpful for eye pain. We're starting to learn a lot about CBD. Here's the key. THC lowers the IOP. CBD raises it. When you get to 30 milligrams of CBD, it can cause your pressure to go up. So that's THC lowers it. If someone's smoking marijuana, it has THC, CBD in it, and that's why you have to smoke a lot to lower the IOP. Someone taking CBD, which is good to know, they're all over the place, it can cause the IOP to go up. So that's why CBD is not great for glaucoma, and it doesn't really have a great analgesic effect that's out there. It's the cannabinoid system. We're learning a lot about it. It's becoming very helpful in other parts of medicine. Really not having a great eye usage yet. Maybe it will come around. It's being used elsewhere very successfully. Doesn't really help with eye pain. CBD causes at higher levels causes the IOP to go up. And so we're learning a lot. It's been helpful in fibromyalgia. People that are addicted to opioids, they're using CBD to kind of plug into those receptors to help with drug addiction. And so there's just, learning a lot about dosing, delivery, and interactions that are out there. All right, I see I'm getting close, so I want to wrap up with a few comments here. Again, I was president of the POA in 2010. I served on the AOA board for 3 years. Our state associations fought for these. I still carry my DEA license. Well, for a reason. I prescribe narcotics, and you heard me talk about tramadol and oxycodone or hydrocodone tonight, the Lortab and the Vicodins. But I've encouraged everyone in my practice, even if they're not going to prescribe, to help show that optometrists carry DEA license, and it helps all those that are still in the state associations and AOA to help move legislation along, because we can go and say, look, we have narcotics and we don't cause part of the problem. So again, hopefully tonight you'll feel more comfortable maybe prescribing tramadol and maybe a hydrocodone product, and really the safety behind it. I don't want to paint it too safe. There is issues, but there are issues, and there are issues with ibuprofen. There are issues with Tylenol. So, it's all double-edged sword. So I hope you don't avoid tonight. And then even if you're not going to prescribe, consider paying that $880 some for 3 years to maybe help your associations out when they're fighting those battles. All right. Let me just wrap up in a minute or two here of cases where I recently used my DEA number. Here's a patient here that she was curling her hair, and her daughter walked in and she turned her head but not her arm, and she hit her eye with a curling iron. This is nothing more than well done epithelium. So this is what we would call an S-char. Two things you could do with that. You can put a bandage contact lens on it and it will be gone tomorrow. You can take it off in the office if you want. This one I would leave alone because it's not falling off. If it was half off, I would probably numb it, take it off, and then put the bandage contact lens on. But this is where I would use, depending on the pain scale, tramadol or Vicodin or Lortab 5/300 or 5 milligrams and 300. 1 or 2 tablets for the next few days. This is the one I thought was going to be a fast talker. He's telling me he works on these little miniature models, and he showed me pictures, and it's really cool. And he has this knife, and he was doing this, and his eye was in a lot of pain. And then I saw this right here, and I said, oh, yeah, I see why you could be. And then I decided to get my OCT, and I said, oh, this is why he's in a lot of pain, because he went 2/3 of the way through his cornea, 400 versus 600. He's kind of 2/3 of his way. He's almost into his anterior chamber. We know the cornea is very innervated, so he's 2/3 of the way. He's got a little RK incision in a sense. If we go back, you can see it starts right about here, and so he's cut a lot of corneal nerves about 2/3 of the way through his cornea. So he was in a lot of pain. I can't remember if it's tramadol or hydrocodone. It would have been based upon the pain scale as we would talk through. This was a guy that was taking off in April, taking off some brakes in his car, and he was prying, and then the screwdriver hit, and he kind of made, like, in a sense, a little screwdriver LASIK flap right here. You could see the sodium fluorescein being pulled into the wound because the endothelial cells kind of are pulling, trying to keep that eye dehydrated or deturgescent, but there's an open wound. You can see that the swelling is occurring. He's got a misshaped pupil. He's got a hyphema, got a hemorrhage over here. And not only that, the screwdriver bounced off and went under his lid, and he has a conjunctival laceration up here. This was a hydrocodone, okay? This was a hydrocodone for a couple days, obviously covering the antibiotic, getting some steroids on board, cycloplegic, trying to minimize the hyphema. This was one where I wasn't going to just cover it with ibuprofen and Tylenol. We already talked about this patient here that was hit in the eye with a tree branch. He's again tramadol or hydrocodone. And my last case here is a patient that went and had a DSEC, didn't know he had to do follow-up, really didn't use the drops, ended up with an endophthalmitis. He came to see me, his eyes in a ton of pain. I did give him some tramadol to make his trip back to Philly, which was about 3 or 4 hours, so that he could see the corneal specialist. But this eye ended up being lost and then ended up being enucleated because they did a vitrectomy, did everything. They just couldn't get it controlled. Just the infection was too bad, and he lost his eye. But I did use some tramadol to get him comfortable as he drove those 4 hours across the turnpike. So, Joe, let's do this last polling question, and we'll see if there's any questions. I know we're at 9:53, but we'll be done by 10 o'clock.
Okay, I've opened the poll,
Yes.
and there was a question. You're for ibuprofen and 2 acetaminophen every 4 hours or just once?
That's a great question. I would do up to 4 hours. Let me explain why there could be a little bit of a back and forth. Remember, Tylenol is allowed. It used to be 4,000 milligrams a day. 2014, they dropped Tylenol down to 3,000 a day. So if I do 4 and 2, you're going to get 1,000 milligrams. And by the rule that's out there, you're only supposed to do 3,000 a day. So you would do 4 and 2. The limiting factor would be the Tylenol. But if it's short acting, I'm only going to do it for 3 or 4 days. I would feel comfortable doing it up to 4 times a day. Remember, it's trying to decrease that liver load. Remember, Tylenol is cleared through the liver. Ibuprofen is cleared through the kidneys. So 4 and 2, 3 times a day if you're going to play it safe, because you're allowed 3,200 milligrams. That's another kind of quick pearl to point out. Ibuprofen, you're allowed 800 milligrams 4 times a day. That's 3,200 milligrams. That means you could take 16 pills of that, and that's 4 times. The limiting factor would be the Tylenol. Again, that would get you at 3,000, so you could do it up to 3 or 4 times a day.
And just to comment that when you mentioned the celebrities who had passed away, including Prince, it reminded me of somebody, and that was an actor named Keith Ledger, very successful from Brokeback Mountain and The Dark Knight. And he had an accidental death overdose. His autopsy found oxycodone, hydrocodone, diazepam, prazopam, and temazepam in there. All of his doctors were cleared of wrongdoing because all the medicines were prescribed legally. And his family confirmed that they were not excessive. The doses were not excessive. It was just a combination that killed him.
Yeah, combination and synergism, right? I mean, that's the key. Synergistic effects, and plugs in, and it's unfortunate. So I see the poll there. I see that a lot of people feel better. 81%, great, and it was a good review. So I knew this would be a review for some, and it would be helpful for others, and that's great. That's out there. You should be able to look at your where it says chat polls and course notes. I don't have the slide in there, but I see where it says survey and the little red dots up. So you should be able to take the survey right now. Joe, any other questions?
No other questions. I think we are good at this point.
Fantastic. So
we can land it.
all right. So everyone, thanks for attending. All questions have been answered. Thanks for interacting. This was Opioid Issues for the Patient and Practitioner. This was a synchronous virtual course. Thanks for attending the National Webinar Series. This will conclude the education.